All right, so this is part 2 of this much larger lecture for grade 5 passive joint mobilizations of the spine. Okay, next we're going to go into the precautions and contraindications, as well as the pre-manipulative assessment associated with each of the different spinal regions. All right, contraindications and precautions of spinal manipulation. So the contraindications and precautions that are presented within this section are ubiquitous across spinal manipulation and peripheral manipulation. It's not specific to a particular body region or spinal region. And then as we go into the pre-manipulative assessments, then we'll get a little bit more specific. So it's helpful to categorize the contraindications and precautions. It allows for better memorization and a more organized, streamlined process when screening your patients for these precautions and contraindications. So for contraindications, there are 7 categories: bone, cancer, congenital conditions, joint instability, neurological, and vascular, as well as other. And then for precautions, it's the same with the exception of cancer and joint instability are ruled out or not included. Okay, so now we'll take those 7 categories of absolute contraindications and break them down a little bit further. So any bony or osseous lesion or something that would compromise the integrity of the bone that may predispose the individual to having a fracture with spinal manipulation and or manual therapy. Avascular necrosis, congenital conditions, infections, inflammatory conditions, metabolic conditions such as advanced osteoporosis or osteomalacia, traumatic events. This could be major or minor, and it could be historic, or it could be in more recent history. And it really depends on the individual and their age, as well as their other comorbidities that may predispose them to having a certain level of trauma that would otherwise put them at risk. Cancers, any form, so spinal cord, malignancy of the spine, meningeal tumors, aggressive types of benign tumors, even outside of the spine, a neoplastic disease of muscle or soft tissue. It should be noted that the spinal column is an area that is commonly a site of malignant cancers or malignancies from non-spinal lesions or cancers, and so again, even if the cancer is otherwise outside of the spine or has shown to be so on recent scans, it is still ill-advised to perform any form of spinal manipulation. Congenital conditions, anything from dysplasias to syringomyelia. And so again, these aren't exhaustive, but it does give you a relatively good comprehensive list of what to potentially question or screen your patients for. Okay, and then neurological conditions, including myelopathies, cord compression, cauda equina, any progressive neurological deficits, be it due to disc herniation or even a nerve root compression. If there's a progressive or acute nature and an evolving neurological insult, then spinal manipulation really is not indicated and should be avoided. Progressive neurological disorders, as well as inflammation or demyelination of the central nervous system that can be discerned through Koenig sign or Lhermitte's sign. Vascular conditions, aortic aneurysm in the lumbar spine, Arnold-Chiari malformations of the upper cervical spine, basilar invaginations of the upper cervical spine, cervical arterial dissections, hematomas in the spinal cord or even intracranially, and then vestibular basilar insufficiency syndrome. And then also severe hemophilia would also be of consideration to avoid manipulation. Final 2 are joint instability and others. So the joint instability really gets to predominantly the upper cervical spine, any hypermobility or conditions that would otherwise predispose someone to having that. So AA instability, this could be anything from Down syndrome to rheumatoid arthritis to Ehlers-Danlos syndrome or other connective tissue disorders. Dislocations of our vertebra obviously wouldn't be appropriate to perform any manual therapy in the setting of that. Signs or patterns of instability, and then internal fixation / stabilization devices. I would say that this is also, you want to be manipulating at that level. However, I know that there are cases in which spinal manipulation away from that or remote from that area have been shown to be therapeutic. All right, and then others are things that are not otherwise categorized or fit into the other 6 buckets. Unremitting, severe, non-mechanical, or night pain conditions that the etiology is not otherwise discerned, lack of diagnosis, lack of indications, lack of patient consent, patient positioning can't be achieved because of pain or physiological resistance, etc. Okay, very similar categories to what we saw with the contraindications. So bone and joint advancement, so advanced degenerative diseases, connective tissue disorders. Again, you're going to want to, as a clinician, kind of risk stratify this person and the appropriateness of whether spinal manipulation would be beneficial. An example here would be osteoporosis. So perhaps the individual has been diagnosed with osteoporosis in their hips or femurs, and or sometimes they will take the DEXA of the non-dominant forearm, such as the left arm in the majority of the population, to get this almost like a surrogate measure of bone stock. And this person may not be osteoporotic at the spine. In fact, they may have positive Z-scores. And in that case, well, then spinal manipulation would, again, be a precaution, but certainly not ruled out. And then you can see these other conditions. I'm not going to read through them, but it is provided within the lab manual, like a small table and checklist that you can kind of go through while screening your patients, either during the medical chart review or during the patient examination. And then from the neurological and vascular, so vertigo, either peripheral and or centrally derived, arterial calcification, and then other categories. Again, disc herniation or prolapse, again in the acute setting where there's an evolving neurological deficit as a result thereof, then it may not be the most appropriate, but certainly in more chronic condition, in more stable clinical presentations, then this has shown to be therapeutic and beneficial. And then I would steer clear of pregnancy. Okay, next is the pre-manipulative assessments for the different regions of the spine. And as we step through this, I'll kind of give you some dialogue and some of the discrepancies and a lot of debate that there has been as far as like the optimal screening methodology or workflow for the different conditions and ensuring someone has low risk and is appropriate for spinal manipulation. As I alluded to, there's been a great deal of debate over the optimal workflow and algorithmic approach to risk stratifying patients and their appropriateness for manipulation and manual therapy over the last 3 decades. And so as a result, it really necessitates us synthesizing the evidence and pulling from multiple resources, multiple experts and research groups in order to really make an informed decision. And so the workflow that I've put together here is a conglomeration of these resources that you see here. Everything from Maitland to the spinal manipulation book and clinical biomechanics from Herzog, also the International Framework for Red Flags of Potential Serious Spinal Pathologies, and the International Federation of Manual Orthopedic Physical Therapy, and then also Gibbons and Tejan have also produced a book that is quite comprehensive and specific to manipulation. So this consensus paper came out in 2017, and I thought it was extremely comprehensive, structured, systematic, and evidence-based. And so we'll use this as a framework for screening each of the different spinal regions, not just the cervical spine, even though the paper was otherwise initially intended for that, and the information provided there is specific to the cervical spine. We'll adapt it to both the thoracic as well as the lumbar spine regions. So looking at the infographic, you can see that there's 6 different sections. So they describe the purpose of the framework, the patient history, the physical exam, moving on to the risk and benefit way out, if you will. And then there's the clinical reasoning and the shared decision-making model, whether spinal manipulation or manual therapy interventions would be appropriate for said patient. And then they even have a 6th section there, which is teaching orthopedic manual therapy and who, what, why, and how to do it. So moving forward with this framework, we'll step through it. So as I alluded to, you have the patient history, followed by the physical exam, the risk and benefits of orthopedic manual therapy or manipulative therapy in said patient, and then the shared decision model, which includes not only the therapeutic alliance and open communication and dialogue, but also consent and treatment planning. Okay, so regardless of the spinal region in question, there's going to be a medical chart review, and within this, you're going to strategically be screening for their problem lists and comorbidities, which will help you to discern contraindications and precautions previously discussed, surgical procedures, current and or historic, medications and imaging if and or available. We have the luxury of being in a large healthcare system where we have ability to have this information kind of pooled to us from multiple sites, even if the patient hasn't received care directly within Stanford Healthcare. However, depending on your practice setting, that may vary. Current conditions, referral notes, diagnoses, SINs, which is their severity, their intensity, the nature, and the stability of their condition, and then also the mechanism of injury. Was it traumatic? Was it more insidious onset, gradual over time? Is there a confirmatory diagnosis associated with their mechanism? All these are considerations that you're going through and thinking through as you go through the preparation for the initial encounter. So it's quite common to have a medical screening intake form. So this is the one that we use here at Stanford Healthcare in the physical therapy department specifically. And it gives a whole host of different yellow and red flags and considerations beyond just what is in the individual's medical chart. Now, it kind of looks like a lot, and there's not much maybe organization to it at first glance. And so it's helpful to kind of break it down into its meaningful parts. Okay, so with the overlay here, I've attempted to kind of organize this sheet so very quickly you can look at it and get a sense as to how it may otherwise, what indications or precautions this patient may have based upon their answering of yes and no. So you have cardiopulmonary conditions in the upper left-hand corner. And some of these that would be consideration for our discussion would be cardiovascular disease, smoking, high cholesterol, history of stroke or TIA, chest pain, and or even shortness of breath. When we're looking at medical conditions, everything from infections such as tuberculosis, and then you have the risk signs of cancer with fatigue, unexplained weakness, weight loss, thyroid problems. And then on the other, in the right-hand column, you have considerations of seizures, which would be suspicious of potentially some central nervous system condition, sudden loss of consciousness, confusion, etc. When we get to joint integrity, as we talked about, not only at the joint specific, but also at the bone and the risk of osseous lesions with osteoporosis and osteopenia. In the cervical spine, you have blurred vision, dizziness, essentially your D's and N's. And then in the lumbar spine, you have your numbness, your tingling, your cauda equina considerations. And so it gives you a general outline or overlay of how you can kind of quickly organize the intake form, which does a really nice job in totality of screening out a lot of the precautions and contraindications that we had previously discussed. As we get into the different spinal specific regions, you'll see that there's a lot of overlap with this, as well as some of the signs and symptoms that can be associated with contraindications to spinal manipulation. Okay, so let's go through the cervical spine using the international framework. So when we start with the patient history, one of the biggest concerns around the cervical spine is vascular pathology. And so you can have a dissecting event or non-dissecting event, and then you can have risk factors, symptoms, and signs associated with each. So let's walk through each of these. So in these tables, you have the risk factor, and then you have the prevalence of that risk factor in the presence of individuals that have a dissection event or a non-dissection event within their vasculature of their cervical spine. So it looks like a lot, again, in there it could be potentially overwhelming for you as the clinician to be able to memorize all this and ensure that you're capturing everything to really appropriately risk stratify and determine that your patient is safe for manual and or manipulative therapy. So one way that I'm hoping to simplify it is that a lot of this is already captured with your medical chart review as well as the intake form. So you can see that's denoted by each of the asterisks shown there. So if we simplify it, it would look like this. So you're going to consider their mechanism of injury and prior trauma. And so you're going to ask that. Vascular anomalies, they may not otherwise know that, but you'll be screening and asking them for that. And then when it comes to oral contraceptives and the infection, then you're also going to know this based off their medical chart. Family history of stroke is not a common question that I ask, but perhaps I should. Again, this was only present in 9% of the dissection events, a little bit higher in the non-dissection events at 14%. And if we do the same for the subsequent table, again, you can see there's a lot of overlap with the vascular anomalies and then the recent infection and trauma. So again, with just 3 or 4 additional questions, you can really rule out each of these different risk factors. And in addition to the medical intake form. Okay, symptoms. So same concept here. When we look at the symptoms in the first column and then the prevalence there within in the dissection event. So headache and neck pain, anywhere between 57 and 80%. So pretty darn high, and a lot of our patients do present to us with both of these conditions. Visual disturbance and dizziness also associated with this, but again, if we reduce the question, synthesize it down to the questions that need to be asked beyond just what you're going to glean from the medical chart as well as the medical intake form, then it's just a couple. And in fact, a lot of these are going to be things that you're, at least for myself, are already included within my standard orthopedic assessment. Yes, there will be a little bit more gleaning that needs to be done or further questioning, particularly like neck pain in itself needs to be teased out. But again, a lot of it's going to be captured, and you'll be surprised that you probably are going to capture a lot of these symptoms, or the patient's going to offer them to you. Okay, and then if we look at the dissection event and we break it up into the vertebral basilar artery, they can have a little bit of different signs associated with it versus your ICA. So if we blank out the ones that are otherwise going to be screened for you, Then you have unsteadiness and ataxia, which likely would be captured based off your gait assessment, and or they would likely tell you that they've felt unstable or unbalanced. And then with the nausea and vomiting, this is an additional question that you would need to ask. Facial palsy and ptosis. So the facial palsy and the ptosis you will likely capture with the objective assessment for your cervical spine. So considerations here would be asking the additional question of any associated nausea or vomiting. Okay, with your internal carotid, a lot of the same signs, but they have different prevalence rates in the presence of a dissecting event. So ptosis, facial palsy, you're going to capture these with your objective assessment for the cervical spine. Your nausea and vomiting, again, would be a question that would be captured, that you would need to ask, but it would hit on the signs and symptoms of both the ICA as well as the VBA. Okay, and then the signs and symptoms that overlap in non-dissecting events for these two arteries. So these look pretty familiar. Ptosis, facial palsy captured within the orthopedic or objective assessment, the unsteadiness of gait and or ataxia, which you may also glean within your gait assessment, or simply the patient may offer that to you if they've felt unbalanced or unstable. Also, our falls risk assessment may also capture this. And then the nausea and vomiting is an additional question that you may otherwise need to ask. Okay, and then it goes into your traditional red flags for your cervical spine. So your D's and N's, your diplopia, your dizziness, your drop attacks, your dysarthria, and your dysphagia. And each of these are otherwise, again, going to be captured within your either your standard workflow for your cervical spine, as these are common questions that at least are within our template, but then these are further asked with the medical intake form. Okay, the and is ataxia or gait, which we talked about. And then the N's are going to be your nausea, your possible vomiting, your numbness, and your nystagmus. So if you're going through your standard, if you have a comprehensive medical review, they fill out the intake form, and you ask your D's and N's, you're capturing almost all of the conditions that otherwise would give you information as to whether this person was at increased risk of having a vascular event with your cervical spine, mobilization and or manipulation. Additional considerations that are worth noting, but again, these are part of your precautions and contraindications. Recent infections, connective tissue disorders, Chiari malformations, Down syndromes. Again, this gets to your upper cervical instability. Okay, so moving on to the physical exam, keeping in mind that no single test alone will provide decision-making information. It needs to be kind of a cluster and a synthesis of the medical chart information that you've gleaned, the patient history, as well as the physical examination findings. So in this transition where you're moving from your patient history to your physical examination, there are some decisions that need to be made. Clinical suspicion of vascular causes is supported by reasoned historical and or clinical examination findings. Again, you haven't necessarily completed your clinical examination findings to this extent, but you will have seen the person, you would have seen them move, you would have seen them walk into the clinic. And if yes, then it may be appropriate to even halt the assessment at this time point, refer for further vascular investigation. If no, are there any precautions or contraindications to proceeding any further? Like, is this person in a state where they can't otherwise tolerate, or potentially there'd be further harm even with the conduction of the physical exam? If yes, your actions are the same. Otherwise, you can conduct the appropriate elements of the physical exam, including neurological examination, co-coordination and gait, blood pressure, auscultations, etc. And again, this is going to be specific for the different spinal regions, and we'll go through that. If there are abnormal findings, such as like a ridiculously high blood pressure or odd things heard on auscultation, or your cranial nerves seem to be off, right, that would indicate further referral, be it for vascular investigation or to the appropriate medical provider. If everything's within normal limits, then eventually we will proceed to the risk and benefit analysis. But let's go through the steps of the physical examination for the cervical spine. So the physical examination components that are laid out here are not your comprehensive cervical spine evaluation for the orthopedic setting. Rather, this is an abbreviated version that helps to determine whether your patient would or would not be appropriate for manipulative therapy. So vital signs, one of the vital signs that usually consistently is reported or suggested in guidelines and consensus statements is blood pressure. But given the technology that we have available to us while you're taking someone's blood pressure, putting a pulse ox on the other finger and counting their respiratory rate would not be a bad idea. Neurological examination, so cranial nerve screening should be performed in all cases. Your upper motor neuron testing would be appropriate based upon the patient's history and or what they've told you in their subjective examination. The same with the peripheral nerves. As a reference point, we provided in the lumbar spine evaluation examination lecture for the Stanford Residency, we provided 9 different conditions or scenarios in which peripheral nerve and lower motor neuron testing would be appropriate. It doesn't need to be on every patient. Canadian cervical spine rules would be appropriate if there is a history of trauma. Cervical examination, including physiological ranges of motion, accessory joint mobility, and cranial ligamentous testing. So it should be noted with the ligamentous testing that current evidence of the predictability of these tests is poor. So the therapist must consider whether this testing is prudent or safe based on the subjective symptoms or if instability may otherwise be present. I will say that the documentation of this within your note may help you should there ever be litigation or lawsuit against you that, again, you could, if you feel there's substantial evidence to otherwise suggest that there's no predictive ability about it, but you also may feel more comfortable standing up there and saying that you did it regardless. Yeah, so it's going to be at your discretion and based off the patient presentation. But we won't be going through it in this lab section. Vertebral artery testing. So numerous studies have brought into question, again, the validity of this in vertebral artery insufficient testing within the clinical setting. Results of the testing may be taken into context of all clinical examination findings. Once again, it has been described more recently. There's been a move away from it as being the standard of care from the standpoint that its validity really hasn't held up. Okay, and then within the actual lab section, we will go through the cranial nerve screening as well as the accessory joint mobility. Physiological range of motion was otherwise captured with the cervical spine examination as part of the curriculum for the residency. Okay, so try and dust off your knowledge of your cranial nerves unless you're currently testing these, but you can do this in a very succinct manner. Usually olfactory is not tested within the clinical setting, at least in the primary care or direct access, unless you have a particular kit or materials are otherwise available to you. Optic testing, you can look at either visual acuity or the the pupil reactivity simply by using the flashlight on the back of your phone, ocular motor, looking at your eye motions in the different quadrants, specifically using a large H where the person does not turn their head but rather tracks your finger. Same with the trochlea. And then with the trigeminal, asking the person to smile and or open their mouth, blow out their cheeks are common tests. Abducens is captured with your visual fields. With the facial nerve, you can have them stick out their tongue. You can have them move it side to side, which will also get at your hypoglossal. And then with the glossopharyngeal, so having them have taste or even having them swallow would be appropriate. If they're following your directions and you're giving that to them auditorily, obviously then cranial nerve 8 is working just fine. And then having them shrug, and again you'll get a sense of their head rotational capacity during your physiological assessment. Okay, when it comes to accessory joint mobility, there are a couple of tests that have been validated against advanced imaging. So the lateral glide test is one of those tests. It came out in 2005, or was validated in 2005 by Fernandez de las Peña. It's a good name to know. He's all over the manipulative research. So what they did is they had therapists perform a lateral glide using the pads of their fingers along the zygapophyseal or the articular pillars of the cervical spine, starting at the C2, C3 level and working their way down the cervical spine at each of the segments. If there was a hypomobile segment, then they either flexed and or extended the neck and performed the lateral glide test again. And they identified hypomobile segments based upon passive mobility, the end feel, as well as the quality of the resistance that was noted to the lateral perturbation or force. So their conclusion was when the therapist identified said level, and then they actually took x-rays in the flexion, extension, and side bending positions, that there was the lateral glide test did show to be a valid clinical test that is as good as radiograph assessment for the diagnosis of intervertebral joint dysfunction in the lower cervical spine, that is to say C3 through C7, in patients presenting with mechanical neck pain, which gives us a lot of confidence because I know I consistently utilize this in the clinical setting, particularly when we're talking about identifying hypomobile segments and those that may be good targets for manual therapy. Okay, and then the next test that was validated by the same research group was the posterior to anterior glide test. It wasn't as ubiquitous across the cervical spine. Particularly, it was only specific to the mid-cervical spine, and it was performed in a position that I don't traditionally do my joint play assessment because of the degrees of freedom that are associated with it. But you can see how they performed it here, where the therapist stood slightly behind the patient, stabilizing the forehead, and then provided a posterior to anterior glide along the different segments of the mid and lower cervical spine, specifically C3, C4, C5, and C6, with the higher validity being shown at C3 and C4 rather than at C5 and C6. It was slightly less if you actually read the paper. That being said, it's important to note what they defined as being hypomobile, and that was an abnormal resistance of quality during the movement, abnormal or hard end field, increased resistance at the end range, and the reproduction of either local or referred pain based upon the patient's complaint. And then you can see that this was also validated again through the mid-cervical spine, with the C3 and C4 segments being of higher diagnostic, having higher diagnostic properties based off the flexion extension radiographs that were taken. Okay, and then lab session. And so we'll go through the cranial nerves as well as those two accessory movements or assessments of the cervical spine. Okay, so now we're going to go through the pre-manipulative assessment for the thoracic spine. You'll note that there is a decent amount of crossover with the subjective questioning and the patient history. However, there are going to be some unique screening elements for the thoracic spine versus the cervical. Though there has been an enormous amount of information and content and research and suggestions and recommendations that have come out for the cervical spine, not as much has come out for standardizing the workflow for the pre-manipulative assessment for the thoracic spine. Yet we know that it's important. And two seminal articles that have highlighted this are shown here, both published in the Journal of Manual and Manipulative Therapy. So the big takeaways from these survey, for the first is a survey of current practice within the UK, as well as a systematic review of the safety of thrust joint manipulation of the thoracic spine, are one, that it's just as important to screen for red flags for the thoracic manipulations as it is for cervical. And second is that the thoracic manipulations can also result in dangerous and or adverse reactions if patients aren't otherwise screened appropriately. What it doesn't necessarily provide is a streamlined or evidence-based workflow that is comprehensive as much as has been delineated for the cervical spine. Okay, so in absence of that standardization, we need to be a little bit more comprehensive. And so taking what is recommended for best practice is shown here. So when it comes to the patient history for the thoracic spine, asking similar questions for the cervical spine screening as you did in the cervical workflow. And then also considering the unique the risk factors that may otherwise predispose individuals to adverse reactions based off spinal manipulation or manual therapy to the thoracic spine. So age greater than 50 years of age, history of trauma, cancer, prolonged corticosteroid use, recent infections, osteoporosis, and fevers and chills. And these aren't completely estranged from that of the cervical spine, but they, particularly the ones that stand out to me are the history of trauma, the older age, and the osteoporosis due to the increased risk of wedge and or osteoporotic-based fractures that can occur within the rib cage and or the thoracic spine itself. And then second is pain that is constant or progressive, non-mechanical, unchanged despite 2 to 4 weeks of treatment, and nocturnal based pain. Again, these are considered to be red flags for spinal regions, be it for the cervical and for the lumbar spine. However, we need to utilize the same scrutiny for the thoracic spine. Okay, and if we look at the risk factors with considerations for those that are otherwise going to be already screened for you within the medical intake form, you can see that the ones that the risk factors that you still need to ask about are history of trauma, which likely will come in not only for the mechanism of injury, but also remote history of trauma is important, and then recent infections. And then additional considerations that are unique for the thoracic spine is symptoms and or difficulty with breathing, though there's shortness of breath on the intake form that may take further coaxing and teasing out with your questioning. Okay, so then what does the physical exam elements consider? And you're going to go through the same sequence and mental steps as you did with the cervical. After my questioning, is there suspicion of vascular and or, in this case, visceral causes supporting by the reasoned historical and or clinical exam findings, or that is to say, though you may not have yet gone through the clinical exam, certainly through the patient history. If yes, referring for further medical management and workup. If no, then are there precautions and contraindications that would preclude or limit the safety of continuing with the physical exam or being more comprehensive there? If yes, again, referring for further medical management. And then if no, then you are safe to continue to progress with the physical exam. If you should find abnormal findings there that are otherwise concerning, determining whether the individual needs to seek medical management right away or it's okay to continue to treat and then simultaneously refer out. And if things are relatively within normal limits, then you would move on to the risk and benefit analysis of whether this individual would be appropriate for manual therapy or or actual manipulative therapy. Okay, so considering the physical examination components for the thoracic spine, once again, you're going to be wanting to take vitals consistent with that of the cervical spine. Emphasis on majority of the guidelines and recommendations are on blood pressure. However, as we alluded to, it's only takes another moment and discretionary effort to capture all elements of the vital signs. Neurological examination is really only appropriate or indicated based upon the patient history and or the EMR. Cranial nerve screening and or upper motor neuron testing when appropriate, which you would get through looking for hyperreflexia and or increased tone within the muscle groups, and then looking for pathological reflexes is also a consideration. When it comes to peripheral nerves, again, they may not be experiencing paresthesias or traditional weakness into their limbs given the distribution of the peripheral nerves of the thoracic spine, but they may actually be experiencing more wraparound or intercostal based pain if there's a nerve root compression there. Hard to kind of test that out, but you can use the Asia scale, which I would defer you to if you really thought there was a neurological insult to the peripheral nerve of the thoracic spine. Cervical spine examination, physiological range of motion, which is kind of a staple and a bread and butter for your standard orthopedic examination of the cervical and or thoracic spine. The unique elements here for the thoracic spine examination are the axial compression. So this is done traditionally with a patient sitting on the edge of the table. The therapist is up over top of them, whether standing on the table or on a higher surface, providing a direct axial load and compression to look at the sensitivity of particularly you're looking for osseous lesions or sensitivity to compression of the spine. You can also do it in the flexed and or extended positions to further exaggerate the anterior and posterior elements of the vertebral body. And then closed fist compression, you can do this as suggested with your closed fist. You can. It's also been described using a reflex hammer. It's relatively quite uncomfortable, but not as uncomfortable as if you were to pick up on an actual osseous lesion, be it rib and or of the compression of the vertebral body itself. Physiological ranges of motion. So of the thoracic spine, you can do this passively as well as actively, or having the patient do it actively and then providing additional overpressure gives you further confluence as far as the direction of the manipulation you may otherwise apply and or whether they're appropriate or not and how sensitive they are to mechanical compression through these ranges of motion. And then finally, accessory ranges of motion, where you can really get onto the intervertebral, the costovertebral, and even the ribs themselves, depending on where the body chart would otherwise indicate their symptoms. Okay, I will say at this time point, I'm going to defer you to the thoracic lecture and lab and or your standardized training for your orthopedic assessment of the thoracic spine that may allow you to go more in depth. Again, the components and elements here are specifically those ones that I want to highlight that are appropriate for pre-screening for the safety of manual therapy and or high velocity, low amplitude thrust mobilizations of the thoracic spine and or thorax. Okay, moving into the lumbar spine. So there is a lot of dialogue around the red flag screening process and what is the comprehensive workflow for determining whether someone's safe for physical therapy, whether they need multidisciplinary management and or they are really at risk and need to be referred out. So we take a lot of consideration of those red flag screening processes and workflows into consideration with the pre-manipulative assessment, because a lot of those red flags that you would otherwise pick up on would preclude someone from being an appropriate candidate for manual therapy and or manipulative therapy. So you have the pre-manipulative assessment consistent with the standard red flags in the lumbar spine. So I'd encourage you to continue to rule those out as you otherwise would, and I'll give a little bit of guidance on that. But the conditions that you're looking to rule out are myelopathy and or cauda equina, osseous lesions, malignancy and or cancer, progressive radiculopathy, osteomyelitis or recent infection, inflammation of the or inflammatory back pain such as ankylosing spondylitis, and then spondylolisthesis of a high grade that would otherwise put someone in an unstable segmental positioning. Same as what you had in the thoracic spine, constant or progressive pain that's non-mechanical, unchanging despite 2 to 4 weeks of treatment, and nocturnal in and of itself. So the other, like the thoracic spine, the other thing that I'm going to turn you to is your standard lumbar spine evaluation slides and lab manual. Again, I have delineated a couple of different resources there for you that may otherwise be helpful for teasing out the appropriateness or looking at the lumbar spine itself. Again, these are populated within the references of this presentation and video. As the primary target audience of this presentation is really for the Stanford Healthcare Orthopedic Physical Therapy residents, you all should have access to the lumbar evaluation and the lab manual that was provided with that lecture content earlier within the year. As you may or may not recall, that within that lab manual that there's a comprehensive checklist for each of the red flags of the lumbar spine that are taken out of the clinical practice guidelines put out by the American Orthopedic Physical Therapy Academy. And if you don't have access to this, say you're listening to this presentation, you're not part of the residency, by all means, I'll provide a hyperlink to the American Orthopedic Physical Therapy Clinical Practice Guidelines there that are published in JOSPT. It was originally done in 2012 and then recently updated in 2018 that would provide similar means by which you can rule out these red flags. Okay, and when you're transitioning to the physical examination, same sequence of questioning that you would otherwise go through with your cervical and or your thoracic spine. So clinical suspicion of vascular and or visceral or non-musculoskeletal conditions. Then you're going to refer for further diagnostic and or medical management. Are there any precautions or contraindications that even conducting the physical exam may not otherwise be safe or appropriate for this patient? If yes, take that same action and get them the care that they need. If no, then by all means continue to move forward with your physical examination elements and your pre-assessment screening for the lumbar spine. If you find abnormal findings within that, then it would be an appropriate means to, again, seek further diagnostics and or medical management. And the treatment-based classification and current best practice otherwise suggests that patients will fall into one of three categories. Are they appropriate for physical therapy? Yes or no. Is physical? If yes, then you would dichotomize them into physical therapy alone or multidisciplinary management to address the additional findings or comorbidities or other concerning findings that may not otherwise be emergent or as urgent as those that would be appropriate in the case of a direct referral where continuing physical therapy interventions and or assessment may be putting the person at greater risk for a reduced outcome or concerns. All right, so then if all within normal limits, then you can proceed with the risk and benefit analysis, which we'll go through in detail. So the physical examination components that would otherwise guide you to determine whether this person is appropriate for manual and or manipulative therapy would be their vital signs, their neurological examinations, upper and motor neuron testing if indicated, right? So you're thinking almost like your central cord compression and be it neurological claudication and or your cauda equina syndrome, and you're usually screening this out with your standard red flag questioning of the lumbar spine, saddle paresthesias, changes in bowel and bladder, changes in their balance and or gait or ataxia, weakness of the lower extremities that is otherwise progressive or associated with the history of the present illness. Peripheral nerves, so you're thinking your radiculopathies and your referred pain down the limb, that they may have the presence of spinal pain or not, and what is the chronicity of these symptoms? What is the progressive nature of them? Is there actual frank neurological deficits such as sensory, reflexes, and motor? And again, one of the contraindications is that progressive and hard neurological symptom that is more kind of in that acute stage with symptoms past the knee. Lumbar spine examination. This is your traditional physiological orthopedic exam of the lumbar spine. You're going through your full ranges of motion. Maybe you're doing repeated motions and overpressures, combined motions, depending on what their sensitivity and their irritability of their symptoms are. And then your accessory ranges of motion of the vertebral column of the lumbar spine. Again, I'm going to defer you to doing a more comprehensive lumbar spine evaluation and encourage you to rest upon your previous training for the lumbar spine that is beyond the confines of this lecture or video, from the standpoint that we're really trying to say what are the need to know elements or components to really determine whether this person is appropriate for manipulative and or manual therapy. Okay, so just quick review. We've gone through the patient history and the physical examination for each of the spinal regions. Now, regardless of the spinal region that the person is presenting with, you would go through the same sequence of events for your risk and benefit analysis, and then also the shared decision-making model. So we'll step through those now. So the risk and benefit analysis, you're looking at low risk of non-musculoskeletal etiology that you've done through the screening process of the medical chart, the patient history, the physical exam, no contraindications or precautions through your screening process, and the international framework for serious spinal conditions uses this sliding spectrum, if you will, of where do you fall. It really is not a dichotomy, unfortunately, of yes and no, but rather there's no concerning features, some concerning features, and some additional concerning features that would otherwise put you at higher suspicion that this patient is either not appropriate for manipulative therapy and or not appropriate for physical therapy in and of itself, be it with adjunct medical management, or potentially just completely sending them off to get further diagnostics and medical management, depending on the seriousness of the suspected etiology. So on the risk side, you're looking at what is the relative risks of this individual. If they're of the low or few concerning elements, then their absolute risk of having an adverse event with manipulative therapy at the hand of a skilled and confident provider is quite low. And then the low relative risk compared to other alternative treatments that are often provided for musculoskeletal and or spinal based pains, such as NSAIDs, where the adverse events are as high as 6%, and considering weighing out the risks of this individual. And simultaneously to that, on the other side of the spectrum, you're looking at the benefit analysis. So there's usually moderate to large effect sizes on pain and disability and functional outcomes when manipulative therapy and manual therapy are provided adjunctively to exercise interventions and to the appropriate patient population. So where's the individual falling on the sliding spectrum that you see below of level of concern? And then if they're on that left-hand side in the low and or few concerning category, then the risk and the benefit of applying the intervention or incorporating the intervention in adjunct to a more comprehensive plan, including exercise, may be appropriate. Okay, if appropriate, depending on what we've gone through thus far, then you're going to go through a shared decision making. And what does this entail? So you're considering the clinical reasoning, your history, your examination, the knowledge of the risks that will be involved for this specific patient, as well as of the intervention itself. So from the practitioner side, you're considering the evaluation, the risks and benefits, alternative treatments, the level of uncertainty that you have or the lack thereof. And then in regards to the patient, what is their story? What are their expectations? Have they had physical therapy and or potentially chiropractic or other similar forms of manual therapy in the past? How did they respond? Did they have a positive or negative experience? What matters to them? What are their values? Are they expecting to come in and get their core strong or work on their deep neck flexors and exercise, or are they more expecting more of a passive form of care? And how can you navigate their narrative, their expectations, and their values? And then finally, the consensual decision making, which is the verbal and or written consent of the patient, the treatment planning of what does it look like if you're going to incorporate manual therapy and or manipulative therapy, how does that occur over time and how is it dosed? And then is it appropriate to have multidisciplinary care, be it within different modalities, or be it physical exercise or otherwise, or are there other additional professionals that you need to bring on board? So a lot of variables go into this pre-manipulative kind of shared decision-making model, and a lot of this is done within just a couple of moments. I know I'm digressing and making what is usually implicit explicit, but it's helpful to kind of map it out and have a theoretical framework of the variables that are leading to our actual actions rather than acting simply based upon cognitive bias. So in summary, these 5 questions are really what guide your pre-manipulative assessment, regardless of the specific spinal region that is in question. Are there any precautions to orthopedic manipulative therapy? Are there any contraindications? What physical tests need to be included based upon the patient's specific location of pain within the spine and or the peripheral joint, and any risks associated with performing said tests? What is the priority for these physical tests to be performed for this patient in particular? Again, we had the decision making of, for instance, like the neurological examination based upon the patient history and presentation. And this is to inform the decision regarding the order of tests and to determine which tests should be completed at that first visit. And then, are the physical tests appropriate, or do they need to be adapted for your specific patient in question? And then finally, if all is well, then you're considering your risk and benefit analysis as well as that shared decision making. Okay, thank you all so much for listening. Please feel free to leave your comments, questions, concerns, and feedback in the sections below, or contact one of us, that is to say myself, Taylor, or Lauren directly. We'd be happy to answer and provide further detail when and where appropriate.